Thanks for thanks for having me. I'm going to start sharing my screen. Okay. So just going to start with a little disclaimer that by viewing this webinar or watching it later, that the Down Syndrome Association in Northeast Ohio is not involved in any medical or legal advice. The information doesn't create a doctor-patient relationship. And I will not be answering any specific questions about any individual people. I'm just giving general information and resources. And the information contained in the webinar is just for general informational purposes and should not be construed as medical or legal advice under any circumstance. So just to begin with a definition of regression. So for all of us, regression is a loss of skills, and it can happen at various times in the life of a person with Down syndrome. And there are many medical and psychosocial causes to be explored. So I want to start with that. Even though dementia and DSRD are causes of regression or loss of skills, almost any major change in health, well-being, environment, anything can cause a regression in everybody, and especially in people with Down syndrome. So you really have to explore deeply to figure out each individual case. At certain times of life, a specific diagnosis may be considered. In a very young child, it could be autism, though I've heard of children as young as 4 being diagnosed with DSRD. So in a child or young adult, it could be DSRD. They generally say teenage to 30s, but this is just evolving diagnosis. Even though it's been around for a long time under various names, really more is just being known about it. I'm not involved in any research on this. I'm just go to a lot of webinars and do a lot of reading and interact with a lot of people who are experts on these two, on Down syndrome, because I have a lot of connections. And then in a person generally considered aged 40 or older with Down syndrome, Alzheimer's may be considered. So, but as I said before, there are many causes of a regression or a change in skills. This slide is adapted from the Advocate Medical Group Adult Down Syndrome Center website. And this is a wonderful website. The center is run by Dr. Brian Chicoine. A lot of you may have heard of him, and just a wealth of information. So if there are any concerns you have, that this is a very good place to go. And you can see from this extensive list of conditions, thyroid, sleep apnea, vision, hearing, stresses, pain, many, many things can cause a regression in a person with Down syndrome. So to use a QR code, if you guys have your phones, because the black and white symbol is called a QR code, and if you shine your phone camera on it, it should bring up a little box. And if you tap the box, it will take you right to that web page. So if anybody would like to do that now, or if anybody's having problems with that, unmute and we can talk you through it, because I have multiple QR codes to link resources. So yeah, you shine your camera at it and it should come up with a little yellow rectangle with the website, and then you tap that and it'll bring that back up. Okay. And then in terms of Down syndrome regression disorder, or DSRD, this has been around for a long time. I have a son who's 33 who has Down syndrome. So, and I remember hearing about this since he was little, but it didn't come to have this name until like the last several years. Sometimes it was called obsessional slowness or Down syndrome disintegration disorder, or there were various names, but in the last 5 to 7 years, Dr. Jonathan Santoro from Children's Hospital of Los Angeles has really, and Dr. Eileen Quinn from Toledo, have really pushed for a cohesive name and diagnostic criteria and are really at the forefront of national experts on this, international experts, actually. So DSRD is thought to be an acute onset of neurologic or psychiatric symptoms in a healthy person with Down syndrome. So this isn't, it might take a while for one to realize, but usually they're talking about loss of skills over months, like acute, like it can even be very sudden from what I've read. This is not like a slow dwindling most of the time. It's usually in a person between ages 10 and 30, but that could expand with further knowledge. And this is very important. No other cause can be found after an extensive medical evaluation. So it's very important because we want to find the easily fixable things like thyroid disease, things like that. We want to make sure somebody's not had a stroke. Like that's why there's a pretty extensive workup that's recommended. So symptoms, sorry, I got to move my little square. Symptoms can include altered mental status or behavior, a change in appetite, being confused or disoriented, and inappropriate laughter or crying. There can be cognitive decline, like people are not interested in their normal activities, they're not finishing activities, and they're not remembering as much. Developmental regression, including withdrawing socially, losing the ability to do like their daily living things like showering or brushing their teeth or feeding themselves, some movement things, difficulty getting really stuck in their routines, and decreased eye contact. There can be a new onset of seizures or neurologic problems, and there can be like they're just not sleeping, like not sleeping at all, or a change in their sleep pattern. Often people notice a loss of language skills, such as decreased speaking, whispering, not speaking at all, or not really seeming to understand speech. There can be movement problems, like freezing or going very slowly. We call that bradykinesia, or catatonia is a big thing they talk about, which is really like a lack of interaction with your environment. But it also can be getting stuck in a position. Like if you put somebody's arm up, they'll just keep their arm up until somebody moves it. Or sometimes you can't even move it, or getting stuck, like walking up the stairs and then halfway up the stairs and the person just stops. There can be random movements. There can be like collapsing, and there can be difficulty walking. Psychiatric symptoms could be there also, like anxiety and depression, delusions, obsessive compulsive, aggression or agitation. And that's, a lot of people with Down syndrome have those. So, that's why it takes an extensive evaluation, because a lot of adults with Down syndrome have anxiety and depression and are obsessive, talk to their imaginary people, have things. So it's sometimes hard to tease that out. So DSRD, as I said, is a diagnosis of inclusion, which means you have to roll everything else out. And then there's ways that DSRD would be diagnosed. And it's important to work with a provider that's knowledgeable about Down syndrome and DSRD, because a lot of people don't know about it. And the evaluation, depending on your center, depending on your person, can involve multiple specialties and can be different for each person. So in this, Dr. Santoro, in this paper, really, they came to a consensus about like, what is it? What are we calling it? And how do we diagnose this? So again, the QR code over here, if anybody wants to get the full paper, shine your camera at the QR code and you can get the paper. And Debbie can send out these slides if she wants, and then you could click on it, but the QR code would give it to you right now. So in the workup, there's imaging, a brain MRI, which, that's the big tube you go into with the magnet, an EEG, lots of blood work, just looking at all your different organ systems, thyroid, looking for any signs of like your immune system being revved up. Because recently, in the last 5 to 7 years, there's been more focus and more insight that at least some cases of DSRD are autoimmune, which means your body is making your own immune system is attacking your body. Whereas like in previous decades, it's been thought to be like totally psychiatric. So they're looking, a lot of these tests are looking for immune problems. As is the lumbar puncture or spinal tap, is looking for signs of infection also, but also immune dysregulation in your spinal fluid. And then there's a much larger list of things that you can do depending on the history and physical. I mean, everything in medicine starts with taking a good history and doing a good physical. So, to get into the details and the updates, this is a very good webinar from Dr. Santoro, put by the National Down Syndrome Society and DSS. So that's at the top. QR code is this. And he is really the expert, he and Eileen Quinn, but he is the guy. And he will work with local doctors. And a lot of people do fly out to Los Angeles to be seen by him. And he does research studies. So he is the guy. And then the second QR code is for the private Facebook group run by Dr. Eileen Quinn out of Toledo, whose daughter Sarah has had regression and been treated for regression. And she runs the Facebook group, which is also a very good source of sharing. A lot of people post on there, and Dr. Santoro and Dr. Quinn post on there also. Okay, so that's the run through of DSRD. And then dementia, just to define it from the National Institutes on Aging, is a loss of cognitive functioning, thinking, remembering, and reasoning to such an extent that it interferes with a person's daily life and activities. And we worry about Alzheimer's disease in people with Down syndrome because one of the theories of why Alzheimer's happens is the amyloid plaques. These gummy plaques develop in the brain, and the amyloid precursor protein, it's called APP, is coded for on chromosome 21. So people with Down syndrome have an extra copy of the gene that can lead to amyloid. And they think that's why people with Down syndrome have a much higher risk of Alzheimer's. So again, this is from the Advocate Medical Group, and there's a QR code. So they advise, like, if you're thinking about Alzheimer's, then you're looking for a pattern of decline with memory, loss of skills, incontinence, change in gait, trouble swallowing, seizures, weight loss, and psychological changes. So you can see a lot of those things are the same as what one can talk about with DSRD. So it is important to have specialists who are familiar with Down syndrome, with the timing, that can ask the right questions and talk to you about the right things to try to distinguish what is going on with your loved one, if it's one of these two things or if it's something totally different. So another great source of information is the National Task Group on Intellectual Disabilities and Dementia. So they came up with the early detection screen for dementia because they were getting requests from families and caregivers to, like, how do we record and talk to clinicians and doctors about these changes. So this is a way to document things you might be seeing and bring it to your person's healthcare provider to document it and see it. And again, this QR code. So it's a tool that the family can use to record changes in abilities. And the Global Down Syndrome Foundation, in their adult medical care guidelines for people with Down syndrome, recommends doing a baseline at age 40. And then you do it, you keep doing it, and you see what's changing over their domain. And it kind of gives you a way to look back and, because it's so hard to remember, well, were they doing that this year? When did this start? 6 months ago? So this is a way to document things. And they picked 40 because usually people don't present before age 40. It's not impossible, but that's to get the baseline and then to see where the changes are. And the NTG has a lot of other resources besides just the EDSD. They do seminars and webinars, and they have a lot of resources on their website. So I encourage you to look there. But this is a good way to track things. And then this is another good webinar, again, from National Down Syndrome Society. Dr. Michael Raffi is a big researcher and clinician on Alzheimer's and Down syndrome. And this is a webinar, Alzheimer's disease and Down syndrome, what we know and what we can do about it, because there is a lot of research actually going on now. I went to the Alzheimer's Association conference virtually this summer, and there is a lot of research on a lot more than before on Alzheimer's and Down syndrome. And there are some clinical trials. There are some things coming up, and Dr. Raffi is very knowledgeable about those. So this is a great webinar. And then just fortuitously, coming up on Friday, March 20th, the Alzheimer's Association has a 3-hour symposium on Down syndrome, intellectual disability, and dementia, and where you'll be able to get a lot of information. So you can do the little QR code, or I did I made a bigger version of it to make sure you can get it to come up on your camera. So this would be great. This would be a great way to get some more information. In terms of local resources, Dr. Parikh at the Cleveland Clinic has treated people with DSRD, and Dr. Wong runs the pediatric Down syndrome clinic. And then other Down syndrome clinics, Pittsburgh has an adult Down syndrome clinic, and I know they do see people from out of state. Cincinnati has their Cincinnati Children's Down Syndrome Clinic, but they also have the Timothy Friedman Center that takes care of adults with disabilities. So that's another resource. And then Columbus has a pediatric and an adult Down syndrome clinic. And then a psychiatrist at University Hospitals of Cleveland, Dr. Tom Scheidemantel, he specializes in psychiatric concerns in people with intellectual disabilities. So he is also one of our local specialists. So I am going to stop sharing. That is the end of my presentation.